of clubfoot. So the learning outcomes for this presentation, after the end of the presentation, I would like everyone to be able to define what is clubfoot, to know a bit of epidemiology of clubfoot even in our own setting, to understand a bit of the etiology and pathophysiology of the condition, and how to make the diagnosis, how to classify, to treat, and also to appreciate some of the complications that come with treatment of the condition. Okay. So in terms of definition, clubfoot is also known as congenital talipes equinovarus, which in simple layman's term that is present at birth, and it is recognized by a foot that is pointed down, rotated inwards or turned inwards. So the acronym CARE is used to describe the deformity, and it is also used in managing the deformity. So essentially, the hind foot is in equinus, that is pointed downwards, and it is also in varus, and the midfoot is in adduction and covers, as well as the forefoot that is adducted. So that picture there is just to show some of the variants or variations of clubfoot or differential diagnosis of clubfoot. By far, the most commonest is the talipes equinovarus that we are going to discuss today. But that is just to illustrate that there can be other types or forms of clubfoot. So in terms of epidemiology, it is a fairly common condition with an incidence overall or globally of between 1 and 2 per 1,000 live births. The incidence is highest in Hawaiians and Maoris, where it can reach up as far as 6.9 per 1,000 live births. But it is important to note that 80% of children born with congenital equinus talipes equinovarus are okay in low to middle income countries. The lowest incidence, however, is found in the Chinese and in the Zimbabwean incidence, according to Madzivirira et al., who conducted a retrospective study at a major referral center, was found to be 0.9 in 1,000. And in terms of male to female ratio, males are affected twice as much as females. This does not mean that it is a sex-linked disorder, but it is due to what is known as the Carter effect, where the female require more of the genes for them to express the condition, but it's not really sex-linked. And it is also important to note in half of the cases, the clubfoot is bilateral. For the types of clubfoot, they are essentially divided into typical and atypical clubfoot. So the typical clubfoot is the one that is found in otherwise normal infants, and it generally is easier to correct, and this can happen with 5 casts or in and around 5 casts, and the long-term outcome with concerted management is good to excellent. And for typical clubfoot, it can be divided into positional clubfoot, which is present at birth, and it is not really a true clubfoot. It is thought to be a result of intrauterine crowding, and it usually corrects with 1 or 2 casts. Then if the typical clubfoot is delayed in terms of being treated, that is beyond 6 months of age, then it is termed delayed treated clubfoot. Then recurrent typical clubfoot occurs when the typical clubfoot is treated, but then there are relapses. The relapses can be due to incorrect or improper technique in the poinsettia management, or incorrect bracing, as we shall discuss later. Then alternatively treated clubfoot, other methods could have been used that are apart from the poinsettia, maybe surgical or other methods like the French or the kite. And for atypical clubfoot, this one is usually associated with other problems, and correction of this type of clubfoot is usually more difficult. The subtypes of the atypical clubfoot include the untreated or neglected typical clubfoot. So if a patient presents 2 years without with their clubfoot having not been treated, it's usually classified as untreated or neglected. Then a rigid or resistant clubfoot, we shall discuss again. These are their slides to discuss some of these ones, so we can move on to the next one. So that one is a rigid or resistant clubfoot. It is typically presents with a crease on the deep posterior portion, and also a transverse crease on the sole of the fist, or also of the feet. Sorry, and then the fifth metatarsal or the fifth toe is hyperextended and short is shown, and sometimes it presents in thin patients or in fat patients, but the outcome or the prognosis is usually poor when it is in the chubby babies. It is usually difficult to correct. Then neglected clubfoot, as I mentioned, if a patient presents at the age of 2 years or more with untreated clubfoot, this is typically how it presents, and it is usually because people could have failed to diagnose the clubfoot early, or they could have presented late at the hospital. So it's two ways: either because of the patients failing to present for appropriate treatment, or they would have presented, but then the practitioners, for lack of knowledge, would have failed to treat the clubfoot. So as you can see, it is quite disfiguring, and the aim of this presentation is to help us be able to make a diagnosis and to prevent people presenting with neglected clubfoot. Then for syndromic clubfoot, the picture on the left is showing a baby with clubfoot associated with arthrogryposis, and then that one on the right is a baby with clubfoot associated with spina meningomyelocele and spina bifida. So syndromic clubfoot is clubfoot in a patient with other syndromes. So there are many syndromes that are associated with clubfoot, like the Beckwith man, the trisomy 18, among many other syndromes. In terms of etiology, the real cause of clubfoot is not known, as you shall see evidenced by the abundance of many theories that have been proposed. So from the very beginning, Hippocrates proposed a mechanical theory postulating that clubfoot would result from a raised intrauterine pressure, but it has been disputed because of absence of increased incidence in multiple gestations, large babies, and polyhydramnios, or which would be normally associated with the increased intrauterine pressure. Then the other theories include the neuromuscular theory, where it has been proposed that there's an increase in the type 1 S to 2 muscle fiber ratio from 1:2 to 7:1. But however, Iran did not observe such abnormality. The histological theories is discussed by various authors. Lorraine found an abnormal peroneus brevis histology, and Iran found a primary germplasm defect, and Shapiro and Lemaitre defects in cartilage. Ionescu increased collagen synthesis, and then Ippolito and Ponseti came up with the theory of restriction fibrosis of the distal muscles of the calf and supporting connective tissue. Again, anatomical theories, Ippolito found out that there was medial angulation of the talar neck and medial tilting and rotation of the board of the talus. Hutnik et al. Found that there's hypoplasia of the anterior tibial artery, and Teko and Porter found an anomalous muscles in 15% of the patients with clubfoot. The theory of arrested fetal development, it was first described by von Volkmann in 1863, and the foot found out that it's actually sorry. All right, sorry for that. Von Volkmann found out actually that congenital clubfoot is a disorder or a deformation of normal development of the foot. So in utero, the foot is normally in equine varus, and this usually corrects to a pronated foot at birth. Arrest due to an intrinsic error or environmental insult results in a failure of correction of the physiological position to a normal pronated foot. So that's the theory of arrested fetal development. Then the consensus theory incorporates all the theories, and it is the one that probably best explains the occurrence of clubfoot. We'll move on now to factors that point towards a genetic factor. So genetic factors have been implicated, but there's been no clear mode of inheritance. But factors that point out to a genetic factor in congenital talipes include the fact that 25% of the cases have positive family history, and in about 2.5 to 6.5%, there's a chance, there's a 2.5 to 6.5 chance of a patient being born with clubfoot if the sibling has clubfoot. And there's a 33% concordance in monozygotic twins, which decreases to 3% if it is in dizygotic twins. And there's been a recent link to that transcription factor PITX1, which all point towards a genetic cause, etiology to clubfoot. Then for environmental factors, these have been found to be linked to congenital or clubfoot. The maternal smoking increases the chance of clubfoot by about 1.3 times. And then early amniocentesis, that is in the period 11 to 13 weeks of gestation, has also been associated with clubfoot. And low birth weight, maternal alcohol consumption have all been linked to clubfoot. In terms of the pathophysiology and pathoanatomy, like I mentioned earlier, it is a developmental deformation, and it has been noted that so there are thickened ligaments and tendons and capsule due to excessive synthesis of collagen. And then the collagen fibers, in terms of arrangement, they've been found to be wave as depicted by the pictures there, the photomicrograph and the slide. And they are small and short leg muscles as well. The arrangement of the fibers into a wavy pattern, also known as crimp, is also used in terms of treatment, because it means the ligaments are easily deformable, and they can also they can unpack, so to speak. In terms of pathoanatomy, the tarsal bones are in extreme flexion, adduction, and inversion. Then the talus is severely plantar flexed, and the talar neck is medially and plantarly deflected, as depicted in that photograph. The navicular is severely medially displaced, and the calcaneus is adducted and inverted under the talus. In terms of making a diagnosis, it is chiefly a clinical diagnosis. And when you encounter a patient with CLUBFOOT, you need to take a thorough history, including prenatal and family history, and then do a thorough physical examination from head to toe, not just concentrating on the foot. The role of prenatal ultrasound is depicted in the slide there. So during the first trimester, you can actually pick up associated anomalies, because some of the CLUBFOOT is associated with other syndromes. And then in the second trimester, that's when you can pick up the true CLUBFOOT. Then in the third trimester, there's a high false positive rate because of intrauterine crowding. Then that ultrasound is just to show a CLUBFOOT in utero, as depicted by the arrow there. Then radiographs are rarely taken, but if they are taken, the recommended views are the takeoff view, which is a dorsiflexion lateral view, which shows a hindfoot parallelism. As you can see, the talus and the calcaneus are almost parallel to each other. And the talocalcaneal angle, that's the angle that is created by lines that are bisecting the long axis of the talus and that of the calcaneus, is less than 25. Normally, it should be between 35 and 50. And then there's also a flat talar head. Then the anterior-posterior view, you also see a hindfoot parallelism, and then the kite angle, which is the angle between the long axis of the talus and that of the calcaneus, is less than 20 degrees. It is normally 25 to 40, sorry. And then if it's less than 20, then you can diagnose CLUBFOOT. Then negative talus first metatarsal angle. As you can see, in a normal foot, the angle between the long axis of the first metatarsal and that of the talus is in the positive. But when it is in a CLUBFOOT, it falls into the negative, as depicted by that arrow. In terms of classification or grading, we commonly use the Pirani for monitoring treatment and early progress, and the other classification or grading systems are also mentioned for completeness, but we will discuss probably the Pirani. So the Pirani scoring basically measures 6 parameters which are graded from 0 to 1, from 0 being normal, 0.5 being a mild abnormality, and 1 being a severe abnormality. There is a mid-foot contracture score, which measures the curved lateral border and the medial crease, as well as the lateral head of the talus. And then there's a hind-foot contracture score, which measures the posterior crease, the rigid equinus, and an empty heel. So for the lateral border, you can place a straight, you can draw a straight line of, on the curved lateral border. So if the line, or if and it is abutting the fifth metatarsal or 50 toe, it's a normal foot. And then if the curve starts just midway along the lateral border, then it's a mild 0.5. And if it is starting quite proximally at the cuboidal joint, then it's a 1. Then the medial crease. So if there are multiple fine creases that do not alter the shape of the foot, then it's a 0. But if there are 1 or 2 deep creases which do not cause significant, that's a mild, and that's a 0.5. But if there are deep creases with a canvas is noted there in 1, then it becomes a 1. Then the lateral head of the talus, if you can palpate completely the head of the talus, then that's a 1. That's the severest form. But if you can palpate it partially, it's a 0.5. If it's not palpable, that's very normal. That's a 0. And the posterior fold, again, like the medial crease, if it's multiple fine creases, 0. 1 or 2 deep creases with no which do not actually for you can visibly see a deformity on the posterior aspect, then it's a 0.5. If you can see a deformity, that's a 1. Then palpation of calcaneus in the heel, you cannot palpate it at all. It's a 1. That's the severest form. And if you can palpate it, the consensus probably is that like that of the nose, and it's a 0.5. And if you can easily palpate it, like you can palpate on your forehead, then it's a 0. And in terms of the equinus, the last one, if you can flex it to neutral, that's a 0.5. That's the mildest. If it cannot be flexed at all, that's the severest. That's the equinus. And if there's some degree of section, it's a 0. That's normal. That's all about the Pirani scoring. Move on now to treatment, and our guest is going to take us through. As a way of a summary, the and operative treatment. And non-operative is the basis of treatment for most of the clubfoot. And of the non-operative method, the Ponseti method is the gold standard in most of the world, and it results in greater than 90% success rate in avoiding extensive surgical release. But for completeness sake, the other methods are mentioned: the French method and the kite method. I will hand over to the next presenter.